The systematic approach allows a more structured resuscitation evaluation. We all have our own nuances, our own preferences in resuscitation diagnostics, but there's no question that a more structured approach can help outcome and also reproducibility. What we want to aim towards is not that each time you see a case, you're reinventing the wheel, but rather you have this structured approach. So when there is the nuances of each case, you can use your cognitive space on that instead of the basics of the resuscitations.
I find having a systematic approach, having a framework of how to approach a declining patient is so helpful in all different kinds of care environments. So my clinical practice is in outpatient medicine. My patients are typically stable, so when we're encountering a declining patient, I'm already feeling a little bit out of my element. It's not our normal day-to-day. Anyone who's providing direct patient care could come across a declining patient. And so we all need to be able to have a tool in our toolkit to be able to take care of them.
It's really easy in our own kind of disciplines and in our own frameworks to kind of get stuck in that framework, and it's hard to think or remember that other people or other groups of professionals might see this in a different way or have a completely different perspective because they focus on a different part of the patient. And I think I've learned so much from being in a interprofessional, multidisciplinary environment in creating this, because we can learn so much about each other, but also with each other in terms of expectations, roles, priorities that we might have that are very different from another profession, but you put them all together and you comprehensively cover the care of the patient.
The complexity of cases continues to grow, and that's unlikely to stop. As medical science advances, clinical care will become increasingly complex. A structured approach like we're describing, cycle of care, primary and secondary survey, that doesn't have to change. Even though there's a lot of complexity coming down, that initial few minutes, that initial resuscitation is still straightforward and manageable, but it's also, I think, attainable by all levels of providers in all environments.
I don't remember a lot of time where I had a safe space to practice where there wasn't a patient on the other end. And so having that opportunity to be able to try things out, to practice, to get to explore those skills without having it being in a live clinical environment, I think is really valuable.
At the bedside, in clinical practice, cognitive load of providers is really high. And that takes a toll cognitively on what am I supposed to do, how am I supposed to do it, is it time to do it, all of that. And the value I see of rapid, but also repetitive practice, almost like muscle memory of a tool like this to assess a patient who's declining, hopefully in the moment, in those high acuity moments for a patient when things are getting kind of scary or unexpected, that if you know something really well, that cognitive load goes down.
When we started this process and having ICU doctors and ER doctors and ambulatory doctors, I don't know that I would have thought that there was a universal framework that we could all use in an approach to a patient. So I think that's what surprised me, is how universal the product is and how, even as I continue to use it in my real life and in my teaching, looking for holes, looking for exceptions, I haven't been able to find them. My experience has been that this is a great way to start and to launch that initial investigation as trying to uncover why this patient is declining.